From that point onwards, I was a very important integral part of all sports activities. I can't play, but I can talk. So the oration parts started. I can't run, but I can ride. I can't jump, but I can paint. So what I can do? Goal number one, that my patient who comes in this meeting has to go at least better informed when he goes back.
Right.
Number two, he should develop a bonding. Define mental health not only in terms of clinical psychiatry, but define mental health as disorder, distress, development. From a stark stigma, many of us will move to what we call a subtle stigma. Psychiatry is a branch with a lot of promise. A lot of attraction that would not be monotonous if you really work on it. Sympathy will burden me. Empathy will give me freedom.
You see, mental health is no more such a big stigma. And why would I say that? Is because of the work of such great people. These people are the ones who have actually changed the way we perceive things about mental health disorders. Not only about disorders, but disorders, distress, and mental development. Today's guest is a very famous personality, an exceptional psychiatrist, a senior social activist, an author, an exceptional orator, a storyteller, a poet, a sketch artist, and the list goes on and on. Yes, I'm talking about Dr. Anand Nadkarni, sir. This is the man who has started the Institute of Psychological Health back in 1990 and is working for the last 4 decades in mental health issues. So without wasting much time, let's get into this conversation, and I'm sure that some of the things said by sir is really going to change the way you practice in your OPD. Or even if you're not a doctor, it's going to definitely help you in way that how you think about things around you. Please enjoy. Good evening, sir.
Good evening.
First of all, thank you so much for accepting my invitation and spending your valuable time in knowing the person that you are and knowing the things that you have done for the society. I would just want your mindset to be magnified in a way that this podcast or this interview mainly aims at those young generation doctors who, with a very fresh set of mind, are trying to enter the field of medicine. Their thought process of why should they take up each of these specialities. And once it comes to psychiatry, I couldn't find of anybody other than you. So I want your insights, sir. So before we start, sir, everybody knows you as an excellent psychiatrist, a senior activist, an excellent orator, a storyteller, an author. But what I want to ask you is, who according to you is Anand Nadkarni as a person?
So first of all, thank you so much for inviting me. And I think, as you said, that who is the person, Anand Nadkarni. So I will say he is a evolving human being.
Okay.
And as any evolving human being will have facets of expression, this human being has some facets of expression. So he keeps on expressing, and through those facets keeps on evolving.
Okay, so very well put, sir. Just as an icebreaker, sir, everybody knows about your work right now, but we just want to know a brief about your past, your childhood, your schooling days, your medical training.
Surely. I had a very happy family, and my father was a college teacher, professor of chemistry, then he became a principal. So we had a very simple yet very beautiful life. I had my upbringing first in Khandesh, Jalgaon, then in Marathwada, Ambezogai, then in Vileparle in the thick of Mumbai, and then finally in Thane. So I had varied backgrounds, and therefore I know the rural background also, how it is to stay in a small town, and also how it is to stay in a big city like Mumbai. So it was a very varied background, but a very rich background in terms of culture, in terms of habits like reading, and in terms of thinking, for which I would say my father was a great source of mentoring. So it was quite a happy one. The coping part of it was when at the age of 6 I had polio, and I had it was first misdiagnosed at that time in Jalgaon. Even the pediatricians were very less in number, so it was misdiagnosed as TBM.
Okay.
Then high fever and all that. Then there was a LP done at home. Who does LP? But it was there at that time. So, and then finally when the fever subsided, then I had lost power in my both my legs. So then the journey for my parents and for me started, because I was not gaining strength in my limbs. So they came down to Mumbai and sought different opinions, and then the power recovered, but then there was a deformity in my leg. So then I was taken to COH, Children's Orthopedic Hospital in Haji Ali. Then I got calipers in both my legs. So till about 11th standard, then my life became very restricted because of the calipers. And but my parents saw to it that I do not go into a inferiority kind of a spiral.
Right.
So with the calipers I took upon the change. So because there was a change, like from coming from Jalgaon to Ambizogai to Vile Parle, even acceptance of students. So in all that, I think I coped up and learnt a few things, that it's important to focus on what you have rather than what you don't have.
Right.
This was given to me by parents, of course, that in Parle Tilak I had come from a rural background, Jalgaon, and who for them I was Gauti kind of a thing, rural background, and I could not play because of my calipers, and I used to feel very dejected that I can't play normally. But then this idea came in my mind that I will learn commentary, and then I learned commentary for about 7 games. So from that point onwards, I was a very important integral part of all sports activities. So finally, till after 7th, 8th, 9th, 10th, I could do excellent commentary from kabaddi to cricket.
Okay.
And even table tennis. So they said that table tennis is such a fast game. How do you do commentary? So I said, you don't do commentary on the game, but you can always do commentary on the players. So I became a very indispensable part like this. So alternatives like this. So I can't play, but I can talk. So the oration parts started. I can't run, but I can write. I can't jump, but I can paint. So what I can do? So that is something that started during that time. Fortunately, after 11th, I went through a series of corrective osteotomies.
Okay.
And with a lot of rigorous physiotherapy and all that, by my inter-science, I had left my calipers.
Okay, excellent.
So there is still a problem with the leg, but it's hardly noticeable. So that was a thing that actually taught me lessons of coping, I suppose. One of the reasons possibly that helps me to empathize with people now, because when you have a coping problem, you have gone through it, you feel that oneness with the person who is suffering in front of you. So this is how I came, and a good student, reasonably good in studies, and coming to medicine was not a conscious decision at all. It's like there are two brothers, elder and younger. Elder brother is very good in maths. He goes to engineering. He goes to UD to become a chemical engineer. The younger one will become doctor. Right now, younger one does not have any liking for mathematics, and you have a choice. At our times, we had inter-science, group A, group B. So biology and maths. We used to leave maths.
Right.
Biology was good. So I came into medicine.
Okay.
So came into GS Medical College very, very fortunately. And I think 10 years of GS Medical College. I'm very, very grateful to my alma mater. It gave me mentors. It actually molded my personality. And in those 10 years from UG to PG to job of a lecturer, those 10 years have been, I think, foundation years of my life. So whatever I have it looks as achieved or achievements, those 10 years have been very, very pivotal. And during my UG, my inclination towards psychiatry came because of a very interesting point, a book. A book by Ivan Illich called The Medical Nemesis.
Yes.
And this book was published in, I read it in 77, 78 as a young, I joined medicine in 1976. So by the standard of the book coming here, it was recent.
Okay.
At that time. So one editor of a publishing house called Granthali, so this Mr. Dinkar Gangal, he suggested to me that why don't you translate this book into Marathi. So this book Ivan Illich has written on medicalization of life, and it essentially talks about the two competing models of medicine.
Okay.
One is called a biomedical model, which all of us learn through tradition, and the second is called biopsychosocial, or a more holistic model of medicine. Now, when I read that book and I said, I can't translate this book without having the Indian ethos to it.
Right.
So I suggested to them that I will Indianize this book.
Okay.
So as a result of that, this was my first ever structured self-study in life. So, which came, I think, very early and very nicely in my second MBBS. So, no net, no such things, but the great library of GS Medical College at disposal, which I started using left, right and center. And I was doing a host of other things during that time. So from drama, elocution, Marathi Vangmay Mandal, I was also a GS of my college.
Okay.
And getting enough marks to pass and doing these things. So, Dr. M.L. Kothari, Dr. Ravi Bapar, Dr. Sharadini Dhawanukar, all my mentors were there. And I wrote my first book. So my point is that a young medical student studying these concepts told me that I don't want to go to a branch which belongs completely to biomedical model. So let me go to mind, because biopsychosocial means psycho. So let me go to mind. So that was one of the important aspects of me coming to psychiatry, and also influence of all these teachers who were in a way practicing holistic medicine in their own branches. So I came to psychiatry. In between, I failed in general medicine in third MBBS. More because of a skirmish with an examiner and very miscommunication on my part. But I had to pay the price for that. And I went through another turmoil and coping, because otherwise excellent, blameless career, and in an important examination like third MBBS, you fail. So again, my father, my parents helped me to come out of this. And of course, I had to give only one subject, so which I gave after 6 months, and also passed with distinction and all that. So that's a separate story about which also I have written in my books. So after that, getting psychiatry was very easy because I was first in the batch.
Right.
Right. So in fact, people were telling me that you take pediatrics, take neurology, take general med, right? Because at that time, psychiatry did not have a. It was more a stigma than any kind of glory. But I was sure by that time that what I want to do. And this was possibly the first major decision that I took on my own. My mother was also against this because my maternal uncle suffered from schizophrenia and was in mental asylums for more than 15 to 17 years. After I joined my PG, he was one of the first this was the intervention that I did with my family first. To get him out of that mental hospital and have a family concerted rehabilitation effort, right, for him also, but that was later. So I went to psychiatry, and in first 2-3 months of psychiatry, I found that what I am learning is completely biomedical psychiatry, and this is not for what I have come to psychiatry. So I had not learned psychiatry at all at that time, first 2 months, 3 months of residency. And then one day in this kind of a mental or emotional turmoil, I wrote down what I want to do in life. And that is where I said that I want to create an institution that will destigmatize and reduce the distance between mental health and society. I gave it a name also, IPH, same. Only thing was that at that time, Institute for Psychological Health was not a word in vogue, so it was Institute for Psychologically Handicapped. So then there was 10 years between the writing and the inception, so by that time it changed to health. So I wrote this and I said, this is what I want to do in life. So at the weekend I went home and told my father that this is what I want to do. So my father went through that document and said, okay, I would type it out for you. So on his personal typewriter, he typed it out for me, which I took as, blessings of my father. So this is how it started. And then I said that who will teach me holistic psychiatry? So I have to go and explore on my own. So 2 important exploration during my residency. One is in the field of addiction. So I was given this charge of ward of addicts by my seniors, Dr. L.P. Shah, because I was junior most. So
the most difficult
to say. You can't say no. So I took it, and then what we were practicing was what we can call today as a revolving door psychiatry. Patients used to come, we used to make them good, we used to treat their withdrawals and all. They will go back and they will relapse, come back, revolving, going out, coming in, going out, coming in. So I said, abhi kya karne ka? So then 8 out of 10 used to do like this. So then I said, let me study the 2 people who have not come back. The 2 people who are on follow-up and who are abstinent. So then I heard about this Alcoholics Anonymous. So with my patients, I started attending AA meetings. And I attended all the 90 meetings that are actually required for any person who wants to leave addiction. And I very closely listened to the stories of all people. And I got friends even up to this point, lot of friends. Then I said, I am going to the meetings, and why shouldn't I take a meeting? So I started group therapies at KM Hospital. So I did not know what group therapy is. Theory books did not teach me anything. But I said I have 2 goals. Goal number 1, that my patient who comes in this meeting has to go at least better informed when he goes back. Number 2, he should develop a bonding. So for that, I have to have different models. And then I started improvising, and the one group a week, then one morning group, one evening group, separate group for family members. Then came narcotics, so another group. So it went on. It was a lone crusader. And that lone crusade again took a very active turn when the brown sugar part and the narcotics came in 84, 85. And best thing is that nobody stopped me. And so on my own, I could do many of these things. I had a rudimentary slideshow which I took to the nooks and corners of this city. So in around 2.5 years, I not only passed my MD, but I conducted almost 700 shows on brown sugar wherever I went. So I went to addas, I went to police stations, I saw Mumbai, I saw the problem, I talked to people. So that was this one part through which later on Muktangan De-Addiction Center. At that point I did not know that Muktangan is going to come. It's going to be an organization which will be completing 40 years now. Now I lead that organization. And we are going to have an organization that has won President's Gold Medal for this treatment of excellence in de-addiction. We are also ISO organization. At any given point in that residential setup, we have more than 175 addicts. So all that is 40 years, but it all started as a personal junoon that this is what has to be done now, and if I don't do it, who will do it? So that is how it all started. So that is the addiction part. And the second part where I felt that yes, holistic approach works. Today at Muktangan, my 60% of team is recovered addicts.
That's a huge number.
That's a huge number, right? So that is what is biopsychosocial. That is what is holistic. And so the second influence on me was type 1 diabetes in children. So one of my mentors, Dr. Vijay Asgaonkar, who was a diabetician, he involved me in 1980s. I was not even coming into psychiatry in his work with type 1 diabetic kids. And that gave me another confirmation that holistic works. We have research papers that our Juvenile Diabetic Foundation kids, after coming into our setup, how their insulin dose comes down, how their blood sugar fluctuations come down, how their quality of life improves. So this was another pioneering effort at that time in the country, of which I was fortunate to be a part. So I started taking groups of my kids, the parents, camps, relatable role models. Many of the things that we do at IPH now, I started doing with these kids.
Okay.
So again, I experienced that this works.
Right.
This works across everything. So with that conviction, then IPH started.
Right.
That in 1990, 10 years passed, that now you can do something unique in this field, which nobody has done, but which means that you have to do it again. So define mental health not only in terms of clinical psychiatry, but define mental health as disorder, distress, development. And you go with that model, and therefore our motto of IPH is mental health for all. Sudhrud Man Sarvansati.
Right.
So this is how we all started.
Right. Excellent. That was everything put, not in short, but everything in detail, sir. Thank you so much for that. As you said, in the last 4 decades, you entered MD psychiatry 4 decades back, and you must have yourself seen that 4 decades is a huge term for any field to evolve. You must be seeing students nowadays who are entering into psychiatry or who have inclination towards psychiatry. What is the bare minimum thing that you feel that the person, the post MBBS candidate should have before taking up psychiatry?
Very nice. See, the point is, even today, if a person decides that I want to do only biological psychiatry.
Mm.
Leave apart all that I have done, the biopsychosocial and all that. Still the person can be a very competent clinician,
Okay.
right? And that is an option, right? To be a very competent biological psychiatrist, right? With empathy.
That goes with everything.
That goes with everything,
Right.
right? Now, if you really want to come into this biopsychosocial part, then you will have to add skills to it. So, which means that you will have to have exposure and knowledge and skills about, for example, at least one therapy, even if you are a clinical psychiatrist. Number two, you will have to have knowledge of the complementary things that you have from psychology,
Right.
such as the psychometric assessments. These are there. So you become a very good competent clinical psychiatrist, and you are adding these skills to it
As an add-on to what you
as
are
an add-on to what you are doing.
Right.
And then if you have inclinations, then you can go to the community. And it will not happen that you would do everything for the community. You select your area of community work
Okay.
and do it only in that area. When people tell me that you are doing so many things, I said, okay, because I can do, or it is being done through me, that is why I am doing. But I am not telling anybody to do all these things, the way I did. You should do the things the way you want to do.
Right.
So you can focus on an area where you want to get linked with the community. Isn't
Agreed.
it? So you can do very systematically your psychiatry practice, correct? But what happens is, if you want to do a larger work, then you will require a team.
Right. So true.
Also, for a clinical psychiatrist, now what is the developing spectrum? The acute psychiatry spectrum is also developing. The chronic institutional care, that is one thing which is developing. Institutional care where life care will be required for many neuropsychiatric people. Giving that in a nice, dignified, creative way is going to be a very important point where we will require a lot of psychiatrist entrepreneurs. Acute care, where you have nursing homes, excellent rehabs, where you can keep people for a time period and then leave them. Daycare centers, evolving them, and life care. Such a spectrum, whatever suits your personality and goals, you go for that. But for each and everything, there is a requirement of a team.
Yeah, so true.
And the psychiatric practice today is, even today, more dominantly person-centric.
Agreed.
And there are only psychiatrists coming together. Then they will keep one or two psychologists. So, at least that much, which is fine. But the team approach is necessary. And if your community work improves, you expand it, then you require a much larger team. So that is something which is required. Now, what people do not see is, the clinical psychiatry people, they do not see the link between community work and their practice.
Okay.
Which is very important, that if you do community work, it's going to help your practice. People feel that community work is social work and practice is practice.
Right. So in a way, sir, do you recommend that before taking up psychiatry as your profession, you should get inside the community, know what you belong or know what you want to change in the community, and then maybe take up the decision?
Yeah, and even if you are in medicine, and I am not against you becoming, the aspiring psychiatrist becoming a very good biological psychiatrist.
Right.
Logical use of pharmacotherapy is very important, because we people are much maligned for the kind of pharmacotherapy that we give. And that criticism is not without substance.
Yeah, so true. Yeah, agreed.
So we can take that and give very logical pharmacology, right? And add all those things according to our taste, right? So this is something that is open to us. And then you have in mental health today, the way we look at mental health and not only clinical psychiatry, you have corporate mental health,
right,
where we have been working for last 4 decades. You have sports mental health, where we are working. So then there are many offshoots on which you can work. You need not work on everything.
Right.
So to me, for an aspiring medical graduate, psychiatry is a branch with a lot of promise. A lot of promise. A lot of attraction that would not be monotonous if you really work on it. I can say after spending 44 years with psychiatry that not a single day of me is same.
That is.
And that is so much of a blessing that you do not have monotony, right? So you can develop up to that point where for you every day is fresh, experiences are new.
Right.
So it's a very exciting branch if you ask me. And even in this century, it has so many applications. So it's very exciting. And one more thing is that people who are really serious about taking psychiatry, like I have my students who are now in every part of this state, who have chosen psychiatry, spending some of their time with me during internship. So with me, people stay with me for a month, 15 days, 3 weeks, 4 weeks. When they want to choose, we have that kind of observership.
Okay.
We have observership after you finish and you want to go to practice. We have observerships of 1 month, 2 months. And in those 1 month and 2 months, what the students do is that they follow complete Gurukul Paddhati. So they stay, all my students who are now practicing, at least 20 of them in this state, have stayed with me for 2 months.
Okay.
Because that's the best way of learning.
Excellent, sir.
So that is that these kind of facilities are also available for the more enterprising ones.
So happy to know that, sir. People who are watching and who are actually aspiring for psychiatry will definitely get in touch with you now. IPH, you started with a very clear motto of mental health for all. And what really is impressive for me is the term destigmatization. The word is very easy to understand, but I can understand on practical grounds it must be so difficult.
Yeah.
Even today, when a patient comes to any other field doctor, it's so difficult to convince the parents that there could be something inorganic going on in your child's mind.
Sure.
How did you cope up with this, sir? Destigmatization, how did you start? How did you ignite that fire and how is it spreading?
What's very important is that for us as a strategy at IPH, it evolved. I mean, not that everything was very clear to us, but we started with a umbrella or cafeteria approach. One way that we said that we will work on all the 3 segments: disorder, distress and development.
Right.
So we will have variety of services, variety of activities, variety of projects.
Okay.
So services, activities, projects, events. These are 4 keywords.
Okay.
And we will have many of them. Today, if you look at just the support groups that we run, they are 24.
Okay.
So in one support group activity, there are 24. If you really count the verticals in which today we work with a team of more than 350 people, including volunteers, and that is minus my 8 Ved centers in 8 cities. So you can add aram se another 300 to it. So we focus on almost 200 verticals of mental health.
Oh, okay, that's a lot.
So it's like this, no, that my 23-24 support groups is a vertical. The vocational education direction and harmony with the life skills conclave in 8 cities are 8 verticals.
Right.
So if you count all these verticals, and again the services, projects, activities, events, it's more than 200. So now why this approach? Because unless you have a cafeteria or umbrella approach, you will not make a social mark.
So
Unless you make a social and cultural mark, destigmatization will not happen. It does happen even when I treat an individual patient, but impact doesn't come. So unless you make this kind of concerted approach, you can't make a social mark. So today people come to IPH with that trust. So making IPH a brand itself is destigmatization. Right?
Got it.
And with that, the isolation of psychiatrists also ends. You know. So what happens is that then the acceptance of a mental health professional also increases. Right? And that is something which is very, very important. So now, like when I move out, wherever I go, you know, airport, hotel, people come and take their selfies. People will come and take my signatures, which is not something that I have earned. This is something is destigmatization. It is happening for my science. It is happening for my branch. So I am very humble to take it that this is not for me. This is for my discipline. Right? So once you do that, then the gap between you and the society becomes less.
Right.
So you have to go through 1, layers of mental health, 2, umbrella, 3, quality of service, 4, consistency. Right? So like activity like Ved, 33 years, 114 Veds, 1200 interviews. It's happening. Right? So you have to go from year to year to year to year. So all that is very important for destigmatization. Right? One way destigmatizes the town, adds to the destigmatization. Because then people feel that these are our people here. I attended your Ved as a student, and now when I got a problem as an adult, I said, ye apna aadmi hai.
So
You know, I remembered IPH, and then I said, yahan pe main ja sakta hu. You know, this is how the destigmatization works. So for that, you need to get out of your consultation chair and go to the community. Right? So if you want to make a social impact, right, one of my complaints with our practice of Indian psychiatry is that we have failed to make a social impact, cultural impact. Right? And therefore when as a team, as an organization, when we try to do this, in a way it is helping the whole cause of mental health, and it should also motivate other mental health professionals, you know, to join that. It involves a lot of new skill learning. You know, communication skills, organizational skills, administrative skills. So those things are important, which some people will pick up. Now all people may not pick up all skills, but now you have a team for that.
Right.
So I think this destigmatization, on one side it's an educational experience for the person in the community. It's an enlightening experience for the person who is working in the field. And as it has pains, it has its own perks. Because you can see that perception changing.
Right.
Right. So it's a great journey. It's a challenging journey, but it's a great journey.
That was an excellent insight, sir. On that actually clears a lot of my questions, which I was going to ask, but that we can actually skip through those specific questions. Very important to know, once you talk about destigmatization, also we should talk about perception about mental health issues in the community.
Yeah.
In the last 40 years of your practice, 44 years of your practice, I'm pretty sure the perception of a common man for any mental health issues has significantly changed. Initially, when people used to hide off their depressions, anxieties, panic attacks, now they are themselves coming up and they want help. They want somebody to talk to because of various reasons. It's a sad part, but people actually don't find people to talk to. What are your views on that, and how is this change, this shift of paradigm, according to you, in your daily practice?
The shift of paradigm, one experience is when I am in IPH OPD is different, because here people who have shifted would come.
Okay.
So that would be only a part of the total social spectrum. And
Right.
in India we have so much of diversity in our country that you will somewhere get the same stigma which was there 40 years back.
Okay.
Then you will see stigma in transition. Stigma in transition means that previously people used to say that psychiatrists only give sleeping pills. Now people will say psychiatric drugs have side effects. Now they will say that psychiatric medicines can produce dependence. So what you have done, your stigma is becoming more sophisticated. Stigma is there.
Okay.
Right? So they will talk about side effects. Now they will not talk about neem ki goliyan. That is a change that has happened. So we need to understand that from a stark stigma, many of us will move to what we call a subtle stigma.
Okay.
Stigma will not go immediately. So as professionals, we need to understand ki where is this person. They will come to you. They will get help. They will get better, and they will ask you again and again, कब खत्म होएगा ट्रीटमेंट, कब खत्म होएगा ट्रीटमेंट, which is again a very subtle form of stigma, right? And see, people are very clear that they want to stop treatment, but people do not see that for that they need to change their beliefs, they need to work on their personalities, which is not automatically done. So they don't want to do that, but they want our medication to stop.
Which is indirectly a stigma.
Which is indirectly a stigma only, no? So again this is a stigma कि मैंने दवा लिया ना सब ठीक हो जाएगा. तो दवा लेके कुछ नहीं फर्क पड़ता है is also stigma. और मैं दवा जिंदगी भर लेते रहूँगा, only दवा is also a stigma. So please understand that as you will reach one layer of destigmatization, another layer would come. So it becomes a process where you will go on, correct? But what is important now, the curiosity that is there in the society about mental health is something on which we mental health professionals need to work on. So now whenever people get all Google information in front of me, I never discourage them. I try to direct them. That what is the difference between Google information and the personalized information that a clinician tries to evoke.
Right.
What are the differences and all that. So I never say कि Google लेके आते हैं. So I say ठीक है ना, this shows that you are interested. So let's now redirect your interest, in a different way. So I think these kind of things are going to be there. Right, and therefore I don't feel कि this struggle against destigmatization will have a finite end, कि destigmatization आज है और अभी नहीं है. But you are moving towards little more enlightenment. Yes, we are.
The barrier is getting
the
shorter.
Barriers is getting shorter, and some new barriers, more subtle barriers are getting created. So I think from generation to generation we will have to keep on working on it.
Excellent, excellent. Now, just moving into a new spectrum of talk, I want to know something about mental health in doctors. How open are doctors to talk about their own mental health, or to just put it straight, how many of your patients are doctors themselves?
Yes, some of them are, but I don't have a statistics how many percentage.
Just a rough.
But some of them are. Doctors are, sometimes they can be very naughty patients because they have that I know all Wala syndrome.
That's worse.
Right? And they feel that they know all in all specialties, which is further dangerous, almost delusional. But I think they are also part of the society, and I do a presentation called Physician Heal Thyself. And in that I talk about the values of doctors and how values erosion gives rise to maximum stress.
Okay.
And in my presentation there, I do not talk about do yoga, do stress management course and all that. I talk about take a hard dig at yourself, take a hard look and ask what you are doing, why you are doing and all that.
Okay.
So it's a kind of
Introspection.
confrontation for the doctors. So what is important is occupational stress will be an integral part of all the disciplines, and therefore medical practice will not be invincible in that sense. So we will have our vulnerabilities as human beings also, personalities, support system, occupational stresses and our own ambitions and aspirations and so on and so forth. And the kind of life that we want to live, right? And the dimensions of life that we want to develop, right? So on these more thinking has to go right from the beginning of the career. So you have aspirations to have a name, to be rich and famous, that is great. I mean, nobody denies that. But what else are you doing to become a more evolved human being? So that is something that somebody has to ask, and then somebody will go for some area of development. Somebody would study further, somebody will be an athlete, somebody will be, a marathon runner, somebody will be a singer, somebody will write, somebody will develop those facets of personality without making that excuse of busy practice.
Very well said.
Because we all make excuse of our busy practice, right? And also I see so many fantastic role models who are enjoying their practice and who are also developing themselves. Because that development, it's not only leisure, it's not only time pass. So I would say that do not look at all these things as a time pass, but look at it as a learning leisure. There is a learning, a fascinating learning in that leisure, and that will make the difference between leisure and laziness.
Okay.
Isn't it? So I think that kind of a charting of my path in medical career will be very important. And for that, even as young medical graduates and postgraduates, what do I want from life? What do I want from my lifestyle? What do I want from myself? I think are important questions to be asked and re-asked at all points of careers. So then the stress would become manageable, and we have to keep it manageable in our own disciplines in various ways. So I see many fantastic role models. Fortunately, not everybody gets into distress, or if everybody gets into distress, they would find their own ways to deal with it and develop also. And yes, there is a minuscule of my clients, patients who are from medical field but have entered the realms of disorder.
Okay.
So some ending with clinical depression, some ending with different addictions. So yes, there is a layer of such people also. But I won't say that this happens only with doctors. This could happen with, I think, all professions.
No, but as you very well said, that early setting limits of what you expect from life will make your life much more easier.
Yeah.
So your work in REBT is exceptional. I have been through a lot of Google, of course, is an open source. I've been through many of your videos, YouTube videos. Could you just very shortly just tell us, because very less people know about REBT. So in short, what exactly is REBT and how it helps you? Very short.
Yeah. Rational emotive behavior therapy was developed by Dr. Albert Ellis in last century in America. And as Albert Ellis says that this is a theory, this is a therapy, and this is a philosophy. So it works at all three levels. The disorder distress development, which is the versatility of this therapy. It comes under the umbrella of CBT, the cognitive behavior therapy. It is one of the CBTs. So I was exposed to it almost 30 years back now, as a client myself going through a distress phase in my life. And I learned it not as a therapeutic tool or technique, but as a complete self-help, and from where my journey started. So it is very effective at all three stages, that is one, and therefore it can become a very good platform of your psychoeducation also.
Okay.
So that is something. It is a self-empowering kind of a therapy, and it goes very much in tandem with the Eastern thought,
Okay.
which is a very, very important part. And I have explored REBT from the point of view of its alignments with the Eastern thought. So my work in this field is related to two philosophical streams from the East. So one is the Advaita Vedanta, and second is the Buddhist thought, in which I have studied or tried to study Theravada and Mahayana. So my take into philosophy goes from REBT. And because REBT has a lot of alignments with Eastern thought, Albert Ellis had studied Buddha, but he had very superficial work with the Advaita Vedanta. So these are some of the things where that alignment also attracted me. That this is something that also comes closer to what even our saints are saying. The saints from Maharashtra are saying, you know, what Tukaram and Ramdas and Eknath and Jnaneshwar is a philosopher of a high range, but these people are saying. So that these were the reasons why I got attracted. And then as it evolved, that most of us got trained, then we started training, so we kind of evolved a culture around us of REBT in the IPH team for last so many years. And we applied it in different areas. We applied it in development also, developing athletes, developing artists, developing singers, developing entrepreneurs. So with this wide application and alignment with Eastern thought, for me it has become like my window to explore. So you have to have a window. So I look at everything through that. I am also a student of history, so on our Avan IPH channel, there are many presentations where I try to establish the link between history and mental health. So again, I go to history through REBT, to philosophy through REBT. I go to films with, so you always require that window through which you will go and visit other disciplines.
It's kind of a link.
A link. So, so for me, that REBT is the link.
Excellent, sir. Coming to the end of our discussion, sir, It's a very silly question, but just some. I'm pretty sure everybody would want to know any simple steps for any professions, not just doctors, to rejuvenate your mental health on a daily basis that you would do. Anything that would make your mental well-being a relatively you would be a better person from within as compared to what if you wouldn't do it.
First and the most important point, which I feel for all doctors, all of us, that we are fortunate because we are in a position where empathy can come from us. You know, very fortunate. We see so much of pain in people, physical or emotional or a combination. And if that evokes that compassion and empathy in us, then that is, or that gives us a lot of emotional strength. So, learning and imbibing empathy can be very rejuvenating. Many times people ask all busy doctors of any discipline, you will see that after a busy OPD, some doctors will be tired both physically and mentally. Some doctors will be tired physically, okay, but not mentally. Right? So if you differentiate, then the doctors who have imbibed empathy would get their rejuvenation in the very process of consultation. Right? I run a 8 to 10 hour OPD without a break. Right? So when I say 30 to 40 clients in a day, my energy level for my 40th client is the same as my first client. Not because I have something special to boast about, but this is a gift that empathy gives you. That you are there 100% with that person at that time. Now people ask that when people come to you with so many problems and woes, you must be getting tired. So I said I don't. If I start getting tired,
Something's wrong.
then something is wrong. I am not empathizing, I am only sympathizing.
That's a very deep thought. Yeah.
Because sympathy will burden me, empathy will give me freedom. And if at the end of the day, today we are discussing this at the end of my clinical day, right? So I have started my clinical day at 9:30 and now it's almost 6:30 in the evening. So throughout this day, what has kept me rejuvenated is that gift of empathy, right? So I think that is something that all of us have. I can give you a long list, but I think this is the gist that's very, very important for all of us. But we look at it in our own way as a very dry and mundane procedure. Patient आया, prescription दिया, diagnosis किया, history लिया, finished.
You've changed the way of thinking how I take my OPDs. Excellent, sir. Excellent. Thank you so much, sir. Thank you so much for all your valuable insights, and thank you again for spending your valuable time. It was utmost a pleasure.
Thank you so much.
Thank you so much. Sir.